in transplants, we combine the chemotherapy with the immunological component that we hope to achieve with the graft versus leukemia effect. And now increasingly we have molecular targeting in AML. Okay, so if we just touch on the genetic heterogeneity. So this was from the North American study where they characterized AML and subtyped them into favorable, intermediate, and unfavorable subtypes according to just the genetic subtypes. This was a headline from 2016 where the headline, or at least on the internet, was that scientists uncover 11 types of acute myeloid leukemia. And that came from this lovely place outside Cambridge in Hinxton, where you have the Wellcome Genome Campus, and Prof. Craddock was talking about NGS, and there's something that they have there called an Illumina farm, where they're churning out tons and tons of sequencing data. And this was the publication. That was Eli Papa Emmanuel, who many of us would have heard at either EBMT or ASH or EHA, and Peter Campbell. And they came up with this. It was a collaborative study between the UK and Germany and many other centers, where they subtyped AML according to the cytogenetics and the mutational profile. And that is essentially what you get. The most frequent mutations up here, FLT3, NPM1, DNMT3A, and various other cytogenetic and mutations over here. And you have this long tail of mutations, the rare mutations that occur at lower frequency. But here, this is what we mainly deal with at the left of this graph. And this was incorporated in the AML treatment ELN guidelines from Donor 2017. So as we can see just from this, AML is a very complex disease. And it will require a more precise way of treating it if we want to cure it. This is just an overview of the detectable molecular aberrations from our cohort from King Faisal in Riyadh. And this is just looking at the molecular abnormalities. So we do a standard profile of the FLT3, NPM1, IDH1, 2. But in addition, we look at certain SNPs in the CEP alpha and the WT1, which at least looking through our cohort seem to have some sort of prognostic impact, and we're looking at larger numbers now. But that's FLT3 up here, FLT3 ITD. So under a quarter, and we think it might be maybe slightly less common than it is in the published literature. So just going into FLT3 mutations, it seems first to be described by a Japanese group in 1996. Then in the UK, Panos Kodouridis looking at the UK MRC data, published the outcomes of patients according to FLT3 positivity or negativity. Now that's a picture of Tabuk, and you might be wondering why I'm showing you a picture of Tabuk, because when you look at the early FLT3 papers, there was one name that kept popping out, which was, this was, a lot of these papers were from 20 years ago, late 90s, and you had this FM Abu Dhuhair. So I didn't know who this was, so I went looking for him on the internet, and I found that he is, I think, a professor in Tabuk University now. So a lot of the FLT3 work initially, and I think this is when he was, I think, in Sheffield, was done by one of the Saudi scientists, and he was quite prolific in the time that he was there in characterizing FLT3. So I would like to meet him, and I think it would be nice to have him give a talk about what work he did. So that is a cartoon of the FLT3 receptors. So you have this outer extracellular component, and the mutations that we mainly deal with, the internal tandem duplication happens in this intracellular compartment. And these were some of the targets, or some of the targeted therapies that were in trials some years ago, or many years ago, that's from 2005, trying to target the FLT3 mutated AML. So it is type 3 receptor kinase, the genes on chromosome 13. It is expressed by immature hematopoietic cells in the bone marrow, lymph nodes, and the thymus, and you get a paracrine or autocrine activation of the receptor by the FLT3 ligand. and that results in receptor dimerization, autophosphorylation, and downstream intracellular signaling. So it is important for hematopoiesis. But what you get with a FLT3 mutation is you get a proliferative signals intracellularly without the FLT3 ligand stimulation, a bit like the BCR-ABL story. So it's present in 20 to 30% of AMLs, and we know it's associated with poor outcome. That was a paper from Paranos Kotorides in Blood in 2001 that showed the inferior outcome in ITD positive patients and the relapse rate according to the allelic burden. So the higher the allelic burden, the higher risk of relapse. These were our outcomes from some years ago of the patients with FLT3 positive AML who were transplanted prior to use of any FLT3 inhibitors. And as you can see, these are the FLT3 mutated patients down here in the red dotted line, and these are the FLT3 normal, unmutated rather. So, with the FLT3 story, and on the back of the CML and imatinib story, there was a search for the silver bullet. Could we target FLT3 positive AML in the same way that CML is targeted? And there were a number of drugs that were, trialed. So there was Midostaurin, PKC412, sorafenib. Now we have gilteritinib, but in between you may not see there, but there's some others. So lustortinib in the MRC study did not seem to have wasn't successful as a FLT3 inhibitor. Quizartinib data is emerging, as is crinolinib, and probably gilteritinib is going to be a forerunner, and it's already licensed for relapsed AML. So as for the sorafenib story, there was a SORAML study, which was a randomized, double-blind, placebo-controlled study. It was a phase 2 study of AML patients. 276 patients were enrolled and randomized, and the addition of sorafenib in induction and consolidation and maintenance improved event-free survival and relapse-free survival, but not overall survival. Okay. The other thing to note is that this was a study of all comers. This wasn't a study in FLT3 positive AML. And we know there was a stage when even we tried using it, and many centers use it, and they say because it's FLT3 positive AML. But then the next question would be, well, if you're doing it on the basis of that study, you should treat all patients with AML with sorafenib, because that study wasn't a FLT3 positive AML study. It was all AML patients. A subset of those had FLT3. And that subset was too small to make any meaningful conclusion of the benefit of sorafenib in terms of an overall survival advantage by adding sorafenib. Now, the other thing about sorafenib is the off-target effects and the side effects. So, the relative risk of fever, 1.5 times more. Look at the amount of diarrhea they get, 7 times compared to the placebo. Bleeding, we lost a patient. A patient died of an intracranial hemorrhage who you wouldn't have thought would have died otherwise, a young female. Cardiac events, terrible skin reactions, and anyone who treats patients with hepatocellular carcinoma, renal cell carcinoma, would know the spectrum of skin problems that you can get with sorafenib. Rash. So sorafenib, so that study did not support the use of sorafenib in AML generally, and it's not licensed for that. So I think we would agree up to this point with both, right? Incredible. Then we have this study. After 40 years of not having anything in AML that improved survival, there was the RATIFY study. And this study took many years to reach the New England Journal. I think it was 10 years or so. It was multi-center, and it was an international study across North America, Europe, Australia. It was a phase 3 randomized study of midostaurin versus placebo in induction, consolidation, and 1-year maintenance in FLT3 positive AML. So it was 3,000 plus patients, randomly assigned, as I said, and the randomization was stratified by the subtype of the FLT3 mutation, whether it's point mutation, if it's TKD, or an internal tandem duplication. It was stratified according to the allelic ratio. An allotransplant was allowed, unlike actually some of the later gilteritinib studies where you weren't allowed to transplant the patient, and the primary endpoint was overall survival. And in the end, that's what we're looking for. And that is the upper half of the consort diagram. 3,000 patients screened. In the end, 717 patients were randomized, roughly 50% in each arm. And that's roughly the treatment schema. So you have induction with daunorubicin and cytarabine, standard 3+7, and then you get midostaurin day 8 to 21 at 50 milligrams BID. Now it says 1 to 2 cycles. So if you did a day 21 marrow, which is slightly different from what we normally do, and if there's more than 5% blasts, they would get another cycle of 3+7 with midostaurin. And if they achieve a remission, they then have 4 cycles of consolidation with midostaurin given on the same days of the high-dose RSC, so day 8 to 21, so during aplasia, really. So happens that sometimes somebody on the ward says, oh, I've stopped the midostaurin because the counts have dropped. And you say, well, actually, that's precisely when you give it. And in the Ceraml study, that was also the time that the sorafenib was given. So this is how it's given. You get the cytarabine, standard 200 milligrams per meter squared, daunorubicin or idarubicin, this is how it was allowed, and the midostaurin 50 milligrams, and they're 25 milligram capsules on day 8 to 21. So as I said, variation from our practice. We know, I think, in Jeddah, certainly in Riyadh, we do a day 14 bone marrow. Here it was a day 21 marrow, and it was 5% blast. So if you have more than 5% blast, you give another cycle. So when we first started doing this on this pre-approval, we had to do it on an IRB, but we were still following the Ratify study. We had lots of arguments. People were saying, you can't give the same cycle of something that doesn't work. But well, you know, that's how we've been given it, so if you want to use it, this is what we have to do. So we did it, and actually it worked, and at least in the few patients who had refractory disease. And then this is how it is in consolidation, again, day 8 to 21, and this was the maintenance regimen, so for 12 months they get it daily without a break. The remission rates actually were only slightly better in the midostaurin arm, so it's 59% versus 54%, and that p-value wasn't significant. But this is what, after 40 years of waiting, was good news for anybody treating patients with AML, is that there was actually a overall survival advantage. It doesn't look that impressive. I mean, the median survival was highly significant simply because the line, the 50% survival goes right through those curves. And there is actually a plateau, and the follow-up was long, more than going up to 90 months over there. So that was great news, and midostaurin was better regardless of your allelic ratio and regardless of whether you had, or at least the trend was, certainly overall and the TKD. So they all had a trend, so you didn't have to have an allelic ratio or the subtype of the FLT3 before you decided whether you wanted to give it or not. What we found, and even in the study, is it's actually certainly less toxic than sorafenib. And even, say, for nurses who are treating patients with leukemia on the wards, we found it actually not reasonably well tolerated. So anemia you would expect, but the only other difference in terms of significant side effects was rash, a higher frequency of rash, but again, it's 14% versus 8% in the midostaurin arm, and maybe some more nausea, and we've maybe had a couple of patients who've had problems with nausea and vomiting with midostaurin, and there is a dose adjustment for that. So, now this was of particular interest to us as a center that does a lot of transplants, as it would be for any other transplanter, and that is this, is that for patients, if you look at the blue line, the blue dotted line is patients who had midostaurin and then had a transplant in CR1 versus patients, the red dotted line, so that is the upper line over here. Those are patients who had prior midostaurin and then had a transplant, and that was their survival. So obviously this is a subset, and they've obviously selected themselves. They went into remission and they were fit enough for a transplant. But if you compare that with the patients down here, who were the other set of patients who had a placebo and had a transplant in CR1, then there is a marked difference of almost 15%. That was significant. So you would think that if I can give somebody midostaurin and get them to transplant, then thinking backwards, you're getting them maybe a potentially 15% survival advantage. I know this is a subset analysis, and these were a selected group who went to transplant, but that is encouraging. So what we've tried to therefore to do is get as much midostaurin into our patients, expose them to midostaurin before we take them to a transplant. So that's the midostaurin, and that's a placebo. So some of the challenges would be we had some challenges getting approval prior to the SFDA approval, because we need SFDA approval. I know, and I know our colleague in Jeddah applied for it for the formulary, and hopefully that will happen now, because we may not have this free supply for much longer. So the cost is 507 riyals for a 25 milligram tablet. So that's 2,000 riyals a day. So for 14 days, you're talking about 28,000 riyals. So the cost of your AML induction has just gone up very significantly. And if you want to give 4 cycles, they're talking about 113,000 riyals. So, and if you think of giving maintenance, you're talking about 750,000 riyals. Okay, so it obviously has a cost impact, and hopefully our friends at Novartis will make it very affordable for us. But as it stood, this is how much we thought it would cost. So at the moment, we've been thankfully been getting it on an individual patient program, but as you can see, these drugs aren't cheap. So in terms of approval, the US FDA approved midostaurin for induction and consolidation, but not for the maintenance. And it looks like from data presented at ASH the year before last, that actually the maintenance didn't impact as much on survival. The European Medicines Agency, the EMA, on the other hand, has approved midostaurin for maintenance as well. I'm not sure actually what the status is in the UK for maintenance. Okay. Which is unusual, because usually it's the other way around. Usually it's the Americans that approve everything, and the UK that's a lot more conservative. So there are diagnostics, the lab limitations. So for example, you want to get a rapid, because remember midostaurin that starts on day 8, so you need to get a FLT3 result within the first week. And if you have an in-lab service and you can get a result quickly, that's fine. But if you're sending samples out to another lab, then that will delay incorporation of midostaurin. So there's variable access across centers. There's the costs, and I think it's important that centers, there's a nice kind, when I say nice, I mean like the UK NICE kind, National Institute of Clinical Excellence, where there is an agreement with companies where you have very expensive drugs, where there's a cost effectiveness model against qualities, and then drug prices can be rationalized. Okay, now I'm going to touch on something which may turn out to be slightly controversial in light of Prof. Craddock's responses to the last question. So now we know that, so this was from the German studies some years ago, which suggested that patients with FLT3 mutations benefit from transplant, that there was an improvement in relapse-free survival, not overall survival as I understood it. And we know that one of the most important causes of death following a transplant is relapse. So how can we reduce the risk of relapse? And why do AML patients relapse after transplant? And as Prof. Craddock's already touched on some of this, you have leukemia escape, failure of immune control, you have the microenvironment and sanctuary sites, you have the intrinsic features of the individual's leukemia because of the heterogeneity of the disease we're dealing with, and there's transplant-related factors. So these are some of the maintenance strategies to prevent relapse. So in terms of immunomodulation, you've already touched on some of this, say prophylactic DLIs, if in the absence of GVHD, targeted therapies such as TKIs, IDH inhibitors theoretically, maybe sometime in the future if it works, and there's the epigenetic therapies. But again, as was previously mentioned, we don't have quality phase 3 randomized data, though some say, and some still say, that, well, transplant generally is an evidence-free zone, isn't it? But I suppose it isn't. But that is a school of thought, because a lot of what we do is not based on very good evidence. So an ideal drug would be something that targets a leukemic clone, augments a GVL effect, and has low toxicity in the post-transplant setting with respect to infection, with respect to cytopenias, and with respect to GVHD. And then there's the interactions with your calcineurin inhibitors and antimicrobial prophylaxis and issues of compliance. And cost-effectiveness, of course, at the end. Now, so talking about some of the sorafenib post-transplant maintenance data, and I'll try to say what I'm going to say carefully. So this was the study from YB Chen from Mass Gen, published in BJ Heme, eventually, that seemed to suggest there is an encouraging overall survival in patients who have post-transplant sorafenib. I know this is supposed to be talking about Midostaurin, but as I said, I'll just take the liberty to expand a bit. So this was the Mass Gen experience. 26 sorafenib patients, a small number of patients, and they retrospectively looked at their data, and they found that sorafenib significantly improved overall survival. And these were their curves published in BJ Heme. So it looked like, in a retrospective cohort, even with small numbers, there was some improvement in survival with sorafenib. Now, at this point, apparently they went to Bayer and asked if they would do a randomized study, but Bayer were not interested. They've made all the money that, I don't know if Bayer are here, but they made all the money that they needed to make in HCC and RCC. They're not interested in AML in small numbers, so they weren't interested. So it wasn't going to happen.
2 minutes.
Sorry?
2 minutes.
Okay. So we, with our colleagues in France, Italy, Germany, also published a cohort. Again, it was small numbers of patients who had post-transplant sorafenib. The median age were relatively younger patients, started around day 70. 40% had grade 1 to 2 toxicities. The median follow-up was 18 months. And this was the PFS, and that was the overall survival curve. Now, if you remember the curve that I had shown a while, which I may not have here, but the FLT3 positive survival in our cohort was something like 30%. So we were very, very encouraged, and this was published by a 90% overall survival. With a follow-up, which isn't too bad. I mean, a median survival which was close to 2 to 3 years. Again, I can vouch for the problems of retrospective data. So the overall survival was very impressive for us. And there may be a biological explanation for this, and this was work done, it was collaborative work, but I think mainly came from German authors, where they looked at what sorafenib does in the post-transplant milieu in enhancing a graft versus leukemia effect through IL-15 mediated mechanism. And essentially what this shows is that you had this increased IL-15 production in FLT3 ITD positive cells, and it essentially led to, in an animal model, increased longevity, and this is the control, and this is the mouse treated with sorafenib. And treatment with sorafenib induces an IL-15 in human primary FLT3 ITD leukemic cells, and they also tested it on patient samples. So there seemed to be a plausible biological explanation of some of what we were seeing. But this was a SORMAIN study. It was a phase 2 randomized prospective double-blind study of sorafenib versus placebo. So patients who'd had a transplant, it was international randomized double-blind. patients who were FLT3 ITD who had undergone an allogeneic transplant. So within 60 to 100 days post-transplant, if they were in complete remission, they were then randomized and no GVHD. They could have had GVHD1 because there has been some historic data suggesting that sorafenib may enhance, perhaps through the mechanism that I mentioned, may enhance a GVHD effect. The primary endpoint was RFS, and the secondary endpoint was overall survival. And this was the patient cohort, not huge numbers, certainly nothing as large as the Ratify study, but remember, these were patients who had been transplanted, so it's a smaller cohort. And again, these are the patient characteristics. But essentially, the 2-year relapse-free survival was significantly higher in the sorafenib versus placebo group. And actually, there was an overall survival advantage as well. And I haven't got the slide over here. That was presented at ASH. So, whilst taking on board Pop's comments about this being a small numbers, maybe as mentioned even in the earlier slide, the primary endpoint wasn't overall survival, it was relapse-free survival, but despite that, it seemed to show an overall survival. So we were very encouraged. So we can use it. We, without telling them, we take it from the supply of our medical oncologists, and they keep wondering why they're running out of sorafenib. They always get it, so we don't feel bad about depriving their patients, but we do use it, and we're encouraged, and we should probably continue to use it, and this is probably going to be very controversial in light of what's been said. We actually think, and we're reaching out to people who may be doing something similar, and if you're doing something similar, then again, maybe we can pool the data. So looking at patients who've had pre-transplant sorafenib, and then go to a transplant, and you see that 15% improvement in survival, and then so pre-transplant, so midostaurin, and then post-transplant sorafenib, and maybe you'll get really good outcomes. We think, we hope. So with that, I conclude. If there's any questions?
Thank you, Dr. Sayed. So we have
right. Maybe I should have just stuck to midostaurin.
No, I don't. Well, the first thing is I just wanted to say thank you. It was a great talk. I really, really enjoyed it. It was fantastically thoughtful. I don't actually think we're saying much very different, actually. I think what I said at the end of my talk was that we haven't got good randomized data. We must generate that. One of the things that I and a number of others have found frustrating has been an implication, not by you or your group, but from some groups, that it's not ethical to put people into the 1506 randomized study.
For gilteritinib?
Yeah, and that's something I really did take issue with. I think where we can generate data in areas of uncertainty, this is an area of uncertainty, you've acknowledged that. We are obliged to patients. There are so many examples of small retrospective or small randomized phase 2s that when you do the large phase 3, it just wasn't what we thought it might have been. And that has terribly significant implications for long-term patient care. But I think what I did say was very similar to what you've said, which is that if it can be tolerated and it's available and it doesn't compromise a trial, then like many things in transplant, it's a reasonable thing to do, and we don't have a great evidence base. So I would very much support all of your conclusions. What I am making is a rather more general point, which is that where we can, we are obliged to try and get better randomized data, and I think we're in agreement on that as well.
Sure. I think we do. When the screening happened for the it wasn't the it was the Monarch study. I think this is the post-transplant gilteritinib. I mean, I know. I think even Mark Levis had I think, as he put it, sort of had to grit his teeth and say, okay, we're going to not give somebody sorafenib and randomize them. But so I think, yeah, more data the better, and larger phase 3 data.
The challenge with the retrospective data, just to make it clear, is you have to be alive and not have relapsed to get onto post-transplant sorafenib. You have to not have life-threatening GVHD to get onto post-transplant sorafenib. So it looks encouraging, but let's not fool ourselves. This is a jolly good way of pulling out the best population of patients.
Yeah, it is. I mean, these are the selected patients, whether it's the patients who get to transplant, and even the ones who do, the patients who've got the GVHD are out, and it is actually, it has lots of side effects, and people do find it, and we can't, sometimes we're giving them 200 milligrams once a day, or 200 milligrams, just try to get anything into them that we can, because they don't tolerate it, often whether it's their skin side effects or the diarrhea, but where we can, we do, and we don't know, but at least a year. We definitely need a trial. I think the Somain one gave it for 1 year, and it was, but at least we try to get it into them for 1 year. Okay.
Any question? Okay, so we'll end now the first session, so we can ask chairman for the second session to run the session. Thank you very much.